skin and scream. We don't wanna grow old. We just wanna be young. Play and make believe, come and rescue me. Feel the sun on my skin and scream. We don't wanna grow old. We just wanna have fun.
Good evening. Thank you for joining us for the 2024 Annual Immunisation Update. My name is Phoebe James and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the lands that we are all meeting on today. Pay my respects to elders past, present and emerging. About Slido. If you want a certificate, you will need to fill out the evaluation at the end. It will pop up on your screen. Q&A, please send them through. The plan today is that we're going to collate them, take them offline, have them answered by our wonderful team, and then we will distribute it to you through the newsletter To The Point. At around 7:30, we'll be taking a 10-minute break so you don't get too sick of us. And it is my pleasure to introduce to you Sharon Saxby. She is our clinical nurse consultant with HNE LHD Population Health, and she's going to talk to you about the team. Thanks.
Thanks, Phoebe. It's so great to be back again with you all and to have this opportunity to share what's going on in our world of immunisation. So some have asked us if we've recovered from our COVID years, and I think the best answer is that we have all changed how we operate. So nothing is quite the same and everything is slightly different. So just to let you know, our team has hit the ground running in 2024 and we're running on a really lean side. So some of you will have heard that you will know that Patrick's been working in the Solomon Islands for the past 12 months. So he has had his contract extended over there and he's taken up that offer. Of course, why would Patrick come back to us when he can work in the Solomon Islands? So he has actually resigned from HNE. So we're currently looking to recruit into his spot. So anyone out there who's keen, please look for the advertisement. We'd love to have you. So he's working over there as a Global Health Technical Officer. And Jodie, our wonderful Jodie, is currently on leave. So our present clinical team is really quite small. You'll be meeting our CNCs tonight, clinical nurse consultants, Kirsty Waller and Rebecca Johnson and myself. And we also have Sonia Davison working in our team as an RN. So keep all those calls coming. We just love to hear from you all. So to start our session tonight, I just want to introduce Dr. Peter Murray. If I can change the slide, that would be good. There we go. All good. So Dr. Peter Murray is a public health physician with Hunter New England Public Health Unit. He trained in New South Wales before heading to New Zealand to complete his Public Health Medicine Advanced Traineeship. He has worked with a government agency in New Zealand that decides which medicines and related products are funded in New Zealand. When he's not at work, he's surfing or fulfilling a tennis coaching role for his children. So we're here to just see what Pete has to say.
Good evening, everyone. My name's Pete Murray. I'm one of the public health physicians at Hunter New England. This evening I'll be giving a health protection update with a focus on vaccine preventable diseases. Thank you so very much for the opportunity to present tonight. Particularly like to thank the PHN and the immunisation team at the Public Health Unit for organising tonight's update. Before I do get started though, I want to acknowledge that the lands that we're meeting on today are the traditional and unceded lands of Aboriginal nations. I'm dialing in from beautiful Awabakal country today. I'd just like to pay my respects to elders past, present and emerging, and also acknowledge and extend those respects to any Aboriginal colleagues on the meeting today and in attendance at tonight's session. And I'd also like to acknowledge the incredible work of the Public Health Aboriginal team at the Population Health Unit. So what are the learning outcomes and objectives from tonight's presentation? There are 4 things I'd like you to take away from my presentation. The first is to have an awareness of the current respiratory virus activity in New South Wales. That's COVID, influenza and RSV. Secondly, to have a better understanding of RSV and who's at most at risk of RSV and what new preventative tools that we have. We've got some new exciting tools as well. Thirdly, to provide you an update about measles and the current global situation and how that is relevant for us locally. And finally, to raise awareness about increasing pertussis notifications after a long period of very low pertussis activity. So before diving into specific infections, let's look at respiratory illness activity across Hunter, New England at the moment. Before I look at the slide, I do want to acknowledge the flu tracking team for pulling this together. And I'd just like to acknowledge flu trackers out there. Many of you in the audience will be flu trackers or will have heard of flu tracking, a wonderful Hunter, New England initiative. If you are interested in hearing more about flu tracking or in becoming a flu tracking participant, we can send some information out following this evening's presentations. Let's look at the slide in more detail though. This slide is titled Respiratory Illness Activity, and this graph is for Hunter, New England. So this is Hunter, New England flu tracking participants, the fever and cough rate that's being reported from our local participants. And what we've got on the horizontal axis is the month of the year. On the vertical axis, we've got fever and cough percentage, and we've got different lines which represent different years. So we've got 2022, 2023, and 2024. We also have the 5-year average here in the interrupted green line here. And what this is showing is respiratory illness activity over the course of the year for each year or year to date. And flu tracking has been the mainstay and one of our key surveillance indicators for measuring respiratory activity in the community. And it's very useful for monitoring respiratory activity during the winter months when we have our winter viral illnesses, but it's been incredibly useful during COVID when we've had quite atypical patterns with waves occurring in summer months of respiratory and illness that are due to COVID, as you can see here on this 2022 increase here. Now, key take-homes from this slide for us tonight is looking at the 2024 data. You can see that we started the beginning of the year with some elevated fever and cough rates in our community, but that this is tapered off and has now sort of leveling off here at just under 1% reported fever and cough rates in our community. So why this has dropped is mainly due to falling COVID levels in the community, but we now are just hovering below 1%, and looking ahead and thinking about previous winter illness seasons, we can expect this this line to go up, and for fever and cough rates, respiratory illness activity to increase as we move into the cooler months. So what are the latest updates with COVID and influenza? Firstly, looking at COVID, some good news. We're over the wave that impacted us in Christmas and New Year's, and now we have low levels of COVID activity across New South Wales. We're often asked about what was the dominant sublineage that was driving the most recent wave we've had, and I've got a graph here of a COVID whole genome sequencing results. Unfortunately, my face is covering part of the graph, so I do apologise for that. But on this axis, horizontal axis, we've got time going back to the 5th of August, and on this axis, the vertical axis, we've got the percentage of sequences, proportion of sequences. What I just wanted to highlight here is this mustard colour, that since early December, this mustard colour has taken off and become the dominant sublineage. And this is the JN.1 sublineage that is now the dominant sublineage of COVID in New South Wales, and was the driver of the most recent wave that we had. It's also been driving COVID waves in other jurisdictions as well. Now, we're often asked about what the future holds with COVID, and it's very difficult to get accurate modelling. The modelling is very uncertain in this space, but what I can say is that we should start preparing for another COVID wave in the next 6 months or so, much in keeping with what we've seen over the past few years. We're watching very closely variants and sublineages, and at this stage there's no heir apparent to the JN.1, but as I say, we're watching that very closely, and we'll keep you updated if anything changes in this space. The other update is that ATAGI has released the 2024 COVID COVID-19 booster advice, and now the Australian Immunisation Handbook has been updated to reflect that advice. I'd just like to encourage you to go back and reference that advice, review that advice, and also look at the Australian Immunisation Handbook as well. This booster recommendations covers off all the groups that are recommended for boosters or where boosters should be considered. I think it's really important to highlight the group that needs to be considered, is recommended to have a booster every 6 months, is those aged 75 and older. And so that's an active recommendation for that group to have a booster every 6 months. It's also important to highlight that the ATAGI has reaffirmed their preference for the XBB.1.5 monovalent vaccines as well. So there's been a lot of movement in the ATAGI advice, and I just encourage you to look at the most recent information from ATAGI and also the Australian Immunisation Handbook for further details. Moving to influenza. So currently we have low levels of influenza across New South Wales, but we are seeing increasing activity as we head into the cooler months. So we should see influenza continue to increase. I think though this is a really important time to prepare for winter and to make sure we're planning our vaccination programs and making sure we've got measures in place to increase uptake in the groups who are at highest risk of severe disease and those groups that are funded for a free influenza vaccine. It's important to note that sort of globally there's a debate around the quadrivalent vaccine. So the current quadrivalent vaccine that has been supported by ATAGI for use this influenza season has two influenza A-like viruses and two influenza B-like viruses in them. However, one of those B sublineages, the B Yamagata sublineage, hasn't been detected globally through surveillance for a number of years. Hence, it's functionally extinct, and expert groups globally are discussing what should be in the future seasonal influenza vaccine. So this is something that we could see some movement in the space, or potentially could see the B Yamagata-like virus omitted from future vaccines. So watch this space. Let's now focus on another respiratory virus, respiratory syncytial virus. And the reason why I want to cover this off is we've got some new exciting preventative tools for RSV available to us now. And RSV has a huge burden of disease, and I'm going to talk through the burden of disease and talk through some of these new therapeutics in this new exciting space. Before I do so, I just want to highlight that this is the RSV virion structure. So this is what a very small single RSV virion looks like. And I want to highlight here two things: the attachment glycoprotein, or the G, and the fusion protein F. And the reason why I want to highlight these two things before I go talking about RSV in further detail is that these are the critical components of the virion that allow the virion to attach and invade and infect cells. And the critical thing that's a target of these new vaccines and these new monoclonal antibodies is this fusion protein here, F. And I'll talk about that in a bit more detail as we move through, but I just wanted to give you a sense that this is the critical protein that we're talking about this evening on RSV and is the target of vaccines and our monoclonal antibodies. Let's now look at RSV's burden of disease. So RSV is generally a seasonal virus with peak activity from April to September. If we look at our current surveillance indicators, we have high RSV activity currently across New South Wales. This graph here shows RSV notifications by month. I think it's important to note that RSV was only made notifiable in late 2022. But if we look at this graph, we can see that our numbers and notifications have increased quite significantly over the past few months, which is again highlighting the high level of activity currently seen. Looking at impacts of RSV disease and burden disease patterns, the impacts disproportionately fall into two groups: infants and young children and older adults. In infants, it classically presents as bronchiolitis but can cause other lower respiratory tract infections such as bronchitis and pneumonia, and it's the leading cause of hospitalisations in infants and young children in New South Wales. When thinking about risk factors for RSV in this group, age is a critical risk factor. The younger the infant, the higher the risk of severe outcomes with RSV. Other comorbidities that are really important risk factors include prematurity, chronic neonatal lung disease, certain heart conditions, and certain immune conditions. But there's also other conditions that put infants and young children at risk of RSV. One of the areas where there's been a lot of development is in our understanding of RSV's burden on older adults. So in adults, RSV generally presents as an upper respiratory tract infection. But in older adults, particularly older adults with comorbidities, RSV can cause a lower respiratory tract infection. And key comorbidities we're concerned about here are respiratory disease and heart disease. And it is a key driver of hospitalizations in older adults as well. This is an exciting but busy slide, and I won't dwell too long on this, but it was prepared by PATH and it was updated earlier this year, and it shows all of the RSV vaccines and monoclonal antibodies that are either in development or market approved. And what's exciting is that there's a whole host of different vaccines and immunoglobulins undergoing phase 1, phase 2 and phase 3 trials, but also that there are a number of vaccines and monoclonal antibodies that are currently market approved, including in Australia. And I'm going to talk in a bit more detail about what's currently available in Australia. Let's start by looking at the RSV vaccine for older adults, or Arexvir, that's now available, and we have ATAGI recommendations for its use. And I've summarised the recommendations here, a little snip from the ATAGI advice. This vaccine is really effective at reducing RSV-associated lower respiratory tract infections in older adults. In fact, reduces the risk by 83% and 94% less likely to have severe RSV-associated lower respiratory tract infection. So very effective vaccine. Importantly, what's been studied is its impact over subsequent seasons, and it's shown to have moderate efficacy through 2 seasons as well, which is really promising. Now, Arexvir is available on the private market. It's not currently available on the NIP, but this is something that I think will generate a lot of interest, and it's a really effective vaccine in older age groups, and we currently have recommendations around its use from ATAGI. So having covered off the new vaccine that's available for older adults in Australia, let's now turn to what's happening with infants and young children. Now, for a long time, we've had available a monoclonal antibody for RSV called palivizumab, and that has been available for children who are at the highest risk of severe RSV disease. But it needs to be given monthly, and it's an incredibly expensive monoclonal antibody. There is now a new monoclonal antibody that's available called nirsevimab. And this is a single-dose monoclonal antibody that targets infants and young children during their RSV season, and it offers long-acting passive immunity, and it's highly effective at reducing the risk of hospitalizations once administered. And the target of this monoclonal antibody is against the fusion protein on the RSV virion, which I've just highlighted here. So basically, it's a preformed antibody that you administer to the infant that's got a very long half-life that targets that fusion protein, stops the virus from being able to infect cells. Now, what's exciting about this new monoclonal antibody is, A, it's got a very long half-life. So it lasts the RSV season, so it lasts 5 months. And it's incredibly effective. So we're looking at some of the trial data. It reduced hospitalizations by up to 80%. And real-world data is looking more promising, with some early data from the CDC showing up to 90% effectiveness in reducing the risk of hospitalization. So incredibly effective new agent that we have available to us. So nirsevimab, given how effective it is and given the burden of disease in infants and young children, has been incredibly sought after globally. And there's limited supply globally. It's not available on the NIP. It's also not available on the PBS in Australia. It's not available on the private market either. However, some states are making nirsevimab available this RSV season. In Western Australia and Queensland, all newborn infants and medically at-risk children are able to access nirsevimab. In New South Wales, medically at-risk infants and children are able to access nirsevimab this RSV season, and that's been made available under the RSV Vulnerable Babies Program. So in New South Wales, this Vulnerable Babies Program is being led by the Children's Hospital Network and clinicians in the Children's Hospital Network. Some other private hospitals too will have access to this, but it is being led out of secondary and tertiary care. It has been rolled out in phases depending on supply and availability of nirsevimab. And it will be available in the Hunter New England area through the John Hunter Children's Hospital. Now, given that there is limited supply, experts in the space have crafted eligibility criteria which target nirsevimab to those who can benefit the most from it. Now, looking at the eligibility criteria for nirsevimab in New South Wales, the key groups to be eligible for it are all premature infants, less than 37 weeks gestation at birth, born after the 31st of October 2023. It's on this line here. All Aboriginal and Torres Strait Islander infants born after the 31st of October 2023, and other vulnerable infants, including children and infants with chronic neonatal lung disease, infants with hemodynamically significant congenital heart disease younger than 24 months, and a host of other conditions as well. So the eligibility criteria in New South Wales are targeting those who are most at risk of severe RSV this season. I'm just cognizant of time, and I've got two other issues to cover off, so I'll move through these a bit quicker. Just want to talk about measles first. So measles anywhere is a threat everywhere. And this graph here shows World Health Organization data over time, looking over years and months, and case numbers on the vertical axis. And what I want you to take home from this is in 2019 we had globally had a huge number of measles cases reported, over 540,000. But during COVID, as the border restrictions and public health and social measures were implemented, measles activity decreased substantially. Over this time, also surveillance was disrupted, so we didn't really have a good feel for what was going on. But what was also disrupted during COVID was routine childhood immunisation programs. And over COVID, and because of COVID, millions of children missed out on measles-containing vaccines. And measles is incredibly adept at exploiting immunity gaps. And what we're seeing now as border restrictions are lifted, with greater movement and people are travelling more, and public health and social measures have been lifted, is measles cases are correspondingly increasing and exploiting that immunity gap. And what we're concerned about now is that we're starting to see a number of importations into Australia of measles, but that this trajectory might continue to go up, and we may be seeing another 2019 epidemic of measles. But and that's what we're concerned about. So I just want to reiterate the threat of measles to you all tonight. So in Australia, we're very fortunate. We've been verified as having eliminated endemic measles. And we did that through maintaining high levels of population immunity through vaccination. And measles vaccines are highly effective and very safe. Currently in Australia, we've got a 2-dose measles-containing vaccine schedule, one at 12 months, one at 18 months on the NIP. But I did want to highlight to you that if you have infants and parents of infants who are planning overseas travel, and these infants are aged 6 to 12 months, they can have an MMR 0 dose, which can offer life-saving protection if they're travelling overseas. Now, this is called an MMR 0 because they still need to have the 2 doses as per the schedule when they return from overseas. So this dose at 12 months and 18 months. But this is an important thing to consider if you've got infants who are travelling overseas from 6 to 12 months. The other thing to ask is if you've got patients who are also travelling overseas, adults, adolescents, to just double check whether they've received 2 doses of measles-containing vaccine as well before they travel. So whilst Australia has eliminated endemic measles, we're still at risk of measles importations from overseas, and that risk increases as global case numbers increase. Here's a couple of headlines from New South Wales Health media releases alerting the public to measles cases and to exposure sites. And these have just been from March alone. So we are seeing a number of measles importations recently. And my take-home message for you is to be alert for measles. Consider measles in someone who presents with a clinically compatible illness. Ask about recent overseas travel, or if anyone in the household has travelled overseas. Ask about vaccination status, or look on air and check vaccination status. What we know, looking at measles cases in New South Wales since 2022, just over 90% are either not vaccinated or have an unknown vaccination status. Also ask if they've been to any areas that are listed in recent measles media releases as well. Now, if you're concerned someone's got measles, critical step is to isolate them immediately and then to notify the public health unit promptly. Prompt notification and isolation can help reduce the spread in the community and help reduce the risk of measles to the community. Public health unit can advise you on next steps and also can advise you on testing for measles and what the appropriate tests are. So yeah, just really wanted to highlight that measles is a constant threat, and I just encourage you to be alert to measles. Finally, I'd just like to raise awareness about pertussis. We are seeing increasing pertussis activity across New South Wales and also in the Hunter, New England area. This is demonstrated clearly in this graph, which is pertussis notifications in H&E going back to January 2022. You can see here that over COVID, when we had strong public health and social measures, we barely saw any pertussis. In fact, there were some months we had no cases notified through. But that has changed, and we're seeing a sharp uptick in case numbers. And this is being mirrored across state surveillance as well. And we're concerned we may be entering a pertussis wave or pertussis epidemic, which we used to see every 3 to 4 years. Now, when thinking about pertussis, our priority group to protect is infants, and particularly those infants under the age of 6 months of age who are the most at risk of severe outcomes with pertussis. And our critical tool that we have to protect these infants is vaccination, and particularly making sure that vaccination during pregnancy, that helps protect the newborn and the infant when they're young, but also timely vaccination and NIP vaccines during infancy, childhood and adolescence. But also think about other groups that are recommended in the Australian Immunisation Handbook: new parents, grandparents who might be recommended for a booster too. That's a critical group that can help protect the vulnerable infants. Finally, I'd just like to highlight that if you do have someone with a clinically compatible illness, consider pertussis as a differential and order a PCR, respiratory PCR, and make sure pertussis is included in that testing panel. Thank you so very much for your time this evening. We've covered off some really important health protection issues, and I hope it's been a useful presentation. I do apologise for being slightly over time. Unfortunately, I'm not there in person or in attendance virtually, so if you have any questions, please send them through to the immunisation team and we can follow that up later on this week and next week and get back to you. Again, thank you so much for your time. I hope you enjoy the rest of your evening and have a lovely week. Bye.
Okay, so thank you, Pete. That was awesome, and I was listening to every word in this room. So my name's Beck. I'm Rebecca Johnson. I'm from the H&E PHU, and I'm one of the immunisation CNCs, and I'm sure about 95% of you have talked to me on the phone at some point, so that's always an enjoyable time. Hopefully for you. I feel like some of you are trying to get me off the phone when I'm trying to give you even more information. So I'm going to start by talking about a bit more about flu. Pete's done some really great stuff around the Epi-on flu, and I'm just going to quickly touch on some of the vaccine side of it. Subtitle, just keep calm and vaccinate. I know for a lot of practices this is the most stressful time of the year for you. Your phones are probably running off the hook. Have you got the vaccine yet? When can I come and get my vaccine? So some of the info that Pete touched on already, these charts are from the same source with flu tracking. The optimal time for flu vaccination still remains around mid-April. So we can see, since COVID, we've had some very unpredictable flu seasons. you know, before COVID, we would always tell you peak flu is quite late in this part of New South Wales. Last year, it kind of peaked a bit earlier. It's still a bit unsure as to what exactly will happen, but the recommendation hasn't changed that mid-April is the optimal time to offer your vaccines. So if they're not in your fridge yet, they are coming soon, and nobody's missing out having not received a vaccine just yet. And just coupling that with, you know, our peak protection is around 3 to 4 months of duration. So getting in too early is not necessarily doing your patients a favour. So, you know, don't stress, the vaccines are coming. What's new this year for flu? So the cell-based influenza vaccines may appear in your fridge this year. I had a very stimulating phone conversation right before I prepared these slides with hopefully somebody that's tuned in, and now I have answers. So your flu, there's no preference between your cell-based and your egg-based flu vaccine. So whatever you get is fine. Give it to whoever you're going to give it to. The main difference is your flu virus is grown in your cell culture rather than the hen eggs. And so the main advantage is that we're not relying on hen's eggs to make the vaccines. So adding this vaccine into our arsenal gives us more options. You will notice a bit of a difference with the strain between the egg-based and the cell-based, and that's just simply because not all strains are going to be compatible with each platform, and when that occurs, you're going to get a pretty close match. So that when your patients aren't getting one strain that's better in one vaccine and one strain that's maybe less good in another, they're going to do about the same job, and they're a very close match. They just needed to get one that was suitable for that platform. The other thing that you may see or hear about the cell-based is, you know, around 2017, 2018, there were some studies where the cell-based may have performed a little bit better in some older folk with protection and keeping people out of hospital. But, you know, subsequent studies have been fairly inconsistent, and each vaccine's performed about the same. So there's not a concern that one vaccine's going to do a better job than the other. And that particular study was looking at people over 65, and we offer the adjuvant vaccine for them anyway. So that's the main thing that's different there. So what are we getting in the fridge? So hopefully you've got access to your nice chart that's on this slide here. Hopefully you've got access to your stickers, and you're really going to keep your fridge quite well organised. Really make sure that you're going to get the right brand for the right age. There's no half doses anymore. Kids get a full dose. If they're under 9, they get 2 doses a month apart. That's a once in a lifetime opportunity. So if they missed out on their second dose last year, we don't need to do 2 doses this year. You can just go ahead and vaccinate. All your vaccines are latex free, and egg allergies not an issue with any of the vaccines. ASCIA recommends flu vaccine for egg allergic individuals with nil additional precautions, and that's including your cell-based and your egg-based. So again, no preference. Your eligibility hasn't changed. For your funded vaccines, flu vaccine remains recommended for everybody who would like to be protected against influenza. But your funded doses, you know, has not changed for any children under 5, any adults over 65, all Aboriginal and Torres Strait Islander people, all pregnant women, and your people who have certain medical conditions that I'm sure you're all very familiar with, so I won't list off. But if you're not sure, you can go to the latest ATAGI advice or give us a call. So vaccine and delivery, hopefully a lot of you have your vaccines in your fridge already. It does take about a month for all of the deliveries, so if they're not there yet, they are coming. Make sure your 2023 stock's gone. I did not delete the confirm your pre-allocation point. You don't need to do that anymore, so that's really good news. One less step for very busy practices. But I did write you no longer need to confirm it, so you can tell I was up late preparing these slides. Order enough for a max 4 weeks. You can put in additional orders for influenza, so we don't really want you kind of stocking up your fridge for your whole season. Order enough that you can get through maybe in about, 2 weeks to a month, and then you can order more. And there's some links there for resources, and we'll provide some more in our answers to our questions as well. And then I'm also the next presenter. I won't introduce myself again. But moving on from flu, I just want to touch a little bit on healthcare worker and student vaccination. It seems to present a really significant burden, particularly in the general practice setting at this time of year as new students are coming in through the university. And, we're all looking for work if we don't have any. So there's New South Wales Health is a great place to work. They'll be there getting vaccines, getting new jobs. So I just want to touch on a few things here. So anyone that wants to work in a New South Wales health facility is required to be vaccinated to have that job and safely work in that facility. This isn't secret information. Anybody can access the actual policy. You can access frequently asked questions. You can access the forms that are required. So if it's very overwhelming applying for a new job or starting a new course, if somebody comes in and they're saying, hey, I have to do all of these things for New South Wales Health, and you're thinking, I don't think that's what the handbook recommends, or I don't think that sounds quite right. It probably isn't, and you can access that policy and make sure if you're at all confused. And the policy actually doesn't recommend anything that's not covered by the handbook as well. So certainly question that. It was last updated in August 23. This policy gets reviewed as new advice needs to be considered. There's a great article on ABC News about the current review of the policy, and, the minister's quoted in that saying that this policy is currently out for consultation. So as new information becomes available, that will be updated through the websites and probably on ABC News. It covers, a whole host of vaccine preventable diseases. This is, really a base level immunisation requirement that's supported by the handbook. And depending on where they're going to work, there might be some additional things. It must be met prior to commencement, which is why these guys are sitting in general practice. And temporary compliance can be issued for Hep B, so we just need to get them as up to date as possible. There's some stuff for TB in there, but this is immunisation, and we don't want our heads to explode on that. I'm just going to focus a bit more on some of the trickier schedules to meet these vaccine requirements a few slides in. So I'm not going to go through absolutely everything in the policy. Some of the simple basic stuff. If they need a pertussis booster, give them one. I don't have a slide on that. There's a high level of evidence that's required, a high level of documentation requirement. So I love AIR, just put things on AIR. There is that red card that you can complete. It's now 3 pages. There are some really good instructions on the back, but certainly in my career of dealing with healthcare workers, I don't know how many times I've filled one of them in for the same person. AIR's there forever. Your time may be better spent adding vaccines to AIR if you're trying to help somebody provide documentation. You can enter vaccines that are given by somebody else on AIR, and you can enter them as a generic vaccine if it's a historic record and you're not sure of the brand. But you may often get somebody in that, where are my vaccines? How do I find my vaccines? I'm sure I've had all of my vaccines. And I think there's just a little bit of information up on the slide there that it's helpful to understand the history of vaccination in Australia, what vaccines that person may have been offered, and where to go and look for those vaccines. So I think some key points that are worth looking at is the Australian Child Immunisation Register was launched in 1996. So if we kind of look at, there was a ABS survey done in 1995 looking at 0 to 6 year olds. So somebody that was 6 in 1995 is maybe a 35-year-old sitting in your office now. And if they're kind of, oh no, I had everything that was going, why do I need more vaccines? What's happening? This doesn't sound right. If you look at that stat, there's limitations in how that data was collected, but you're kind of thinking, well, maybe there was just under a 50% chance that you actually may not have had everything that was even recommended at the time. And then acknowledging when we're talking about some things like hepatitis B, we're talking about things like varicella that are recommended to protect healthcare workers. If you're 35 or older, unless you really went out of your way to try and get it, or maybe got caught up in a specialised program, you may not have actually had access to that vaccine. So I think that, just thinking about where they may have been able to access that vaccine, and if they could have accessed it, maybe you could be advising some people not to waste a lot of time digging for records, and they may be better off completing a course with you. There's, little risk with giving somebody a vaccine they may have already had if they can't find those records, and certainly if they were vaccinated before 1996, they've probably got Buckley's of finding that record, unless they've got a mum that kept very good records. So I just want to touch on a couple of the trickier practice points for vaccine schedules. So hepatitis B can get quite complex, particularly for healthcare workers. This is all supported in the handbook when you click on down to serology post-vaccination and then click on to non-responders to hepatitis B vaccine. A question we often get asked is, oh look, I'm doing all of these serologies on these 18, 19-year-olds and they're all not immune. Is our Hep B program even working? And I think it's really important to put that into context, that this has actually been looked at a lot by a lot of systematic reviews, and we know that we do get a robust immune response. The clinical trials for Vaxelis and Immunisation Hexa are greater than 97% seroconversion in those clinical trials. What we know is that you elicit a memory cell response, and that doesn't necessarily continue to be expressed in surface antibodies that you can detect, but many, many, many trials have been conducted, which is why the booster recommendation was dropped, that if we stimulate your immune system, we promote a memory cell response and your antibodies rise. So when you're seeing all these 18-year-olds come through, it's not that the vaccine program didn't work, it's that their body's a little bit lazy. They're not continuing to express those antibodies, but we've got really good data to support that the majority of people are immune. What you're going to do for those people, the first thing you're going to do is give that boost, try and stimulate that memory response, see if we can measure it. And if we can't, you can give another 2 doses 4 weeks apart and do those bloods again. Getting the bloods in at the right time is quite important, because what they're trying to do in this setting is we're just trying to prove that immunity so that they can go and stick their hands inside people and we know that they're protected. So you just want to make sure that you get those bloods in when they're most likely to be expressing immunity. And then I've prepared this really subtle slide regarding measles, mumps and rubella. Again, that the stressed out people trying to get work, trying to study, and they tell you they need bloods for everything. They most certainly do not. If somebody has history of vaccination for measles, mumps, rubella or varicella, you should assume them to be protected based on the documented doses that they've received. Don't do serology. New South Wales Health is not asking for serology. The immunisation handbook doesn't recommend serology. The only time you would use it is, maybe for those folks that are 35 and older that don't have their history and are potentially unwilling to get a vaccine unless serology's done previously. We can't hold people down and vaccinate them. You could do a serology. But certainly The recommendation is you don't need to, and you could offer those people without a history of vaccination that are immune competent who don't have a contraindication to vaccination. You could offer them a 2-dose course and never do serology. But what do you do if you do serology? For MMR, you need to give them a booster if they do have that documented course and you've done serology and it's not immune. You need to give them a booster. If they've had 1 dose, you need to get them up to their 2 doses. If they've had 0 doses, you need to vaccinate them. Varicella is a bit trickier. What's the recommendation? There isn't really one. The handbook really clearly states that the currently available varicella serologies that are available in the labs are not a good match for what's in the vaccine. So when you run a serology on a vaccinated person and it comes back non-immune, how do you interpret that? Because it's measuring a different strain of the virus. The policy doesn't say, oh no, you can ignore it. The handbook doesn't say, oh no, you can ignore it. They say maybe talk to the lab to get a better interpretation on what that means and whether you need to offer additional vaccines. So that's what I'm saying. Ideally, just don't run serology. 28-day interval between those live vaccines. So, you know, if you gave them an MMR and now it turns out you need to do a varicella and it's been 2 days, you've got to wait a month. So it's good to really plan out what you're doing, particularly when you're using live vaccines. And there's some references as to where I got that information from.
Thank you, Rebecca. That was very good, especially the healthcare worker. It's very good to get those bits of advice about MMR and varicella out there because we do get a lot of those questions. So as you know, I'm Sharon Saxby and I'm just going to cover a little bit, clinical nurse consultant in our immunisation team at Hunter New England Public Health. So I'm just stepping in here for a bit and we're going to talk about childhood immunisation rates. And I know that we talk about immunisation rates a lot, but we all know that during COVID things went a little bit awry and we all like to blame COVID for some things, but let's have a look at see how we landed. So children at 1 year of age. So AIR considers children fully vaccinated at 1 year of age if they have their 6-week vaccines, their 4-month and their 6-month vaccines. Okay, so not their 12-month vaccines. So this is where we're sitting for at the state. And you can see here for Hunter New England, I had to add in December 23 data, we've got 94.6%, and for our Aboriginal little kiddies, we've got 93.3%. We're doing pretty well. You can see through the year that that fluctuates a little bit, but how are we going compared to pre-COVID? So in 2019, we were almost equivalent to each other. So our Aboriginal kiddies were actually 0.2% higher, so we were sitting at 95.9%, the other way around, and 95.7%. So we are not doing as well as we did pre-COVID for our 1-year-olds. Our 2-year-olds are measured using their 6-week vaccines, 4 months, 6 months, plus their 12 and their 18-month vaccines. So it's really worth noting in here that, as Pete was alluding to with measles, we're measuring their measles doses in here as well. So how are we going? Not quite so well. 92.7% and 91%. Okay, and in pre-COVID times, we were sitting up more around the 93% mark. It's really worth noting in here that for measles to have really good herd protection, we need to be sitting up around 94 to 95% to keep ourselves protected. And that's as a whole. We have, as Pete was talking about, measles cases coming in from overseas. We've got some locally acquired measles. We just need to find, measles just needs to find those little pockets of lower coverage of vaccination, and we're off. So we really need to be careful. These kiddies here should have received both of their measles vaccinations. So some work to be done. So at 5 years, I need to keep off that button there. At 5 years, one would say we're measuring all their vaccines here. We've got great rates. We should be measuring all their vaccines. Unfortunately, all we're measuring is their 4-year-old Infanrix IPV. So there's a presumption here that all the other vaccinations have been given. So our rates are sitting up pretty well, 95.8, and lo and behold, our Aboriginal kids are sitting at 96.5, which is absolutely fantastic news. Pre-COVID, we were doing a little bit better than that. So our Aboriginal kids were sitting at 97.3%. So we can see our Aboriginal kids are actually considered more fully covered at 5 years of age, but we have to then look back and say it's taken them to 5 years to be fully covered. So we do need to take into account the timeliness of vaccines, and so we need to be working with all of our kids in that respect. They're recommended at times for a reason. So how can we improve our immunisation rates? I know that you guys have tried every scheme under the sun, and we've come up with all sorts of ideas, and it is a really difficult thing to get a grasp on what is it that we're not doing that we could be doing, because understanding why are people not getting vaccinated has been really hard to ascertain. So things that we could try are personal recommendations from you really normalises the vaccination schedule. So that makes parents feel comfortable that this is the normal accepted thing, so they're going to feel much more confident in going ahead with the vaccinations. Big responsibility from you guys. Consider letting some families just drop in. Schedule reminders either by phone calls or letters. Making the next vaccine appointment at your current visit. So you get my bubby in for their 6-week vaccines. While they're there, encourage the parents to make their appointment for the 4-month vaccines, ensuring that the appointment is made when or after they turn 4 months, not 3 weeks beforehand. Checking air for every child so you can correct the records or give the correct vaccine if they come in for a vaccine appointment. But also, every time that child comes in for an appointment for anything, maybe consider getting the doctors or the nurses, whoever's seeing that child, to actually check air to identify if there are any due or overdue vaccines that you could actually catch up on that day. You may actually find that some of your parents will come in with a letter from our practice, and you may wonder, how do they get a letter? How are they so special that they're getting a letter from our practice? It's probably because they're overdue. And that letter is sent out because every month we run our 11A report from AIR, and that is looking at all the children who are overdue. And just the last few months we've had a particular interest in looking at children in that 9 to 12 months age bracket. So we're looking kids in that bracket who AIR are identifying as overdue. And Sonia is looking after all of that at the moment in Jodie's absence. And lots of phone calls are made. We follow up with practices to see whether the practices where the child was last seen have got records of vaccines that have not been added to AIR. We check up with the parents to see whether they are actually declining vaccinations. We go and make lots of different phone calls to see if we can track down those records. We've discovered that a large portion of overdue records are really due to either missing data from AIR, so they have been vaccinated, it just hasn't been uploaded to AIR, incorrect data entry onto AIR. So you get those dosing numbers wrong, they're not going to show up as being vaccinated. Okay, they're going to sit there as either duplicate dose or given at the wrong time or something. So it's really worth looking at your data before you enter it into AIR. And duplicate records. We have children who end up with 2 different records and they've got vaccinations on one, but the other one comes up as overdue. So there's a lot of different things in there. So there's a lot of work that we can do and you guys can do to ensure that children's records are up to date and therefore we have them as fully vaccinated. Just remember that the immunisation providers are responsible for the follow-up of their patients. So we may well contact practices and just little Jimmy Smith is missing some vaccines. We can tell you what they're due if you haven't got records of anything, but it's your responsibility to follow up with that child as parents and to see if you can bring them in for an appointment. Understanding that that's difficult sometimes because little Jimmy Smith came and saw you 6 months ago and has never been back since, and that's the first time they've been to see you. So they may well have moved on, but do all that you can to follow up that child. And just remember that incomplete records on AIR affect their no jab, no play and no jab, no pay. So no jab, no play can affect their entry into childcare. If they're looking to put their child into childcare, they cannot enrol unless they're fully vaccinated at that time or on a catch-up schedule or have an exemption, a medical exemption. And no jab, no pay means that they may be missing out on receipt of family tax benefits or childcare fee assistance. So there's lots of different reasons why we need to ensure that records go up onto AIR. We have a wonderful Aboriginal immunisation team. So we have Katrina Clark, who's our Aboriginal immunisation manager, and Hannah Briggs, our Aboriginal immunisation healthcare worker. Hannah sits in Tamworth, Katrina sits in Wallsend with us. She's just returned back to us from a stint down at NCS. We're really delighted to have her back. So Katrina was one of the instigators in the pre-call program for our Aboriginal children. So that works by, we get a list every week of all the children who identify as Aboriginal or Torres Strait Islander born within a Hunter New England health facility. We get that every week. And these children go onto a database, and at 4 weeks of age, their parent receives a phone call to talk about immunisations, to remind them that their immunisations are coming up in a few weeks, and then they get permission to be able to send an SMS reminder 2 weeks before every immunisation milestone. So that's a connection that they're making with families for our Aboriginal kids to ensure that they're receiving their timely vaccines and that any questions are answered, and they can find places for these parents to go to get their vaccines given to their child. So if you have any questions at all about any Aboriginal parents who may have questions, please reach out to Katrina and Hannah. Can I say in there too, it is your responsibility to identify whether people, if a child identifies as Aboriginal and Torres Strait Islander as well, just so that you can recommend the correct vaccines for them as well. We get asked a lot of questions. I know it's not childhood rates, but we get asked a lot of questions about meningococcal A, C, W, I and B. So this was a good point to highlight the difference between recommendations and funded. So people go to the handbook and they see lots of recommendations for any vaccine, and they think, you beauty, here we go, it's recommended, let's give it. But there is a difference between recommended and funded. Lots of things are recommended for lots of people because it's the best thing for that person. But funded is where the vaccine is going to be provided free under the NIP, and they are very two different things. So for recommendations for meningococcal, it's really good to go to the handbook and have a really good read. You can see there that lots of people are recommended to have meningococcal vaccines, all for very good reasons. But who are they funded for? So meningococcal, ACWY, or Niemann-Ricks as it is at the moment, is funded at 12 months of age on the NIP, in Year 10 in the school program, and for asplenia, hyposplenia, complement deficiency and treatment with eculizumab. Okay, so that's meningococcal ACWY. So as you can see from the slide before, recommended for lots more people, but this is who it's funded for. Meningococcal B is funded for Bexsero, asplenia, hyposplenia, complement deficiency and treatment with eculizumab. So you may say, what about our Aboriginal bubbies? We know it's funded for them as well. So it is funded for our Aboriginal bubbies. That's funded at 6 weeks, 4 months and 12 months. Okay, and then at 6 months if there's eligible medical conditions. The catch-up program for Bexsero for our Aboriginal kids is still going up to the age of 2. So they need to have started their catch-up by the age of 2. You can complete them after they turn 2, but once they turn 2, that catch-up is not available to them. So this is where it's really good to remember to be identifying our babies that are Aboriginal or Torres Strait Islander, so that you can recommend all the different vaccines that are to the parent that child is eligible for. Okay, and that is your clinical responsibility. It's a very big responsibility. So we don't, a lot of people will come in, and if we don't recommend different vaccines, they won't think to ask about them, and they won't know what is available for their child. And we do know that Aboriginal and Torres Strait Islander babies under the age of 2 are at increased risk, 2 to 3 times more likely to have serious disease from meningococcal B. That's why we are doing this program, offering the NIP vaccines for them. So a little bit of what Beck was talking about before, identifying when people may have had different vaccines. We get a lot of phone calls with people declaring that they had vaccines in every year of school, that they've had all these vaccines. Even a little bit of a personal story, my husband went in to have a hepatitis B vaccine, and the GP told him that he probably didn't need it because he would have had it as a child. My husband's a little bit too old to have had it as a child, so a little bit of education is needed. So there are lots of different places that we can go to have a look at what vaccines were available and available to who at different times. So NCs have the history of immunisation in Australia. It lists all the different diseases and then goes through with pages of when all these different vaccines came into Australia, who they were funded for, if they were funded, who they were available for. So that's a really good resource to have a look at. Also, vaccines offered in the school program. We didn't offer every vaccine every year to every student. So it's really worthwhile having a look at that form. It's on our website, on the back of the requesting your vaccination records form. It's really good to have a bit of look and see what was given when, so that you know whether you're chasing up a tree that doesn't really matter. So I'd just like to acknowledge all of you guys. You do a wonderful job. We'd like to work together. We know that vaccines work, but they only work if we stick them in the arm and they're given correctly. So keep doing a great job, and please don't hesitate to reach out. So thank you. I think we're going to have a 10-minute break now.
We just wanna be play and make believe, come and rescue me. Feel the sun on my skin and scream. We don't wanna grow up. We just wanna be play and make believe, come and rescue me. Feel the sun on my skin and scream. We don't wanna grow up. We just wanna have fun. Wild and free, baby, we could dream farther than our eyes have ever seen. I don't wanna grow up. Never grow up, no. We're too young to talk about forever, talk about the weather, to know any better. I just want to laugh until I can't breathe. Midnight moonlight dancing, never get enough sleep. Oh, the whole night through. And we could count the distant tumbling stars from the roof of our cars, letting go of our hearts. Close your eyes, pretend that it's your first kiss. Darling, can you feel it? Oh, so ignorant bliss. Oh, the whole night through. 'Cause we don't wanna grow up. We just wanna be play and make believe, come and rescue me. Feel the sun on my skin and scream. We don't wanna grow up. We just wanna have fun. Wild and free, baby, we could dream farther than our eyes have ever seen. I don't wanna grow up. Baby, could we misbehave a bit more? Never know what's in store when we're rowdy and bored. Honey, can we catch some floating fireflies? Let 'em light our way tonight through the neverland skies. Oh, the whole night through. 'Cause we don't wanna grow up. We just wanna be play and make believe, come and rescue me. Feel the sun on my skin and scream. We don't wanna grow up. We just wanna have fun. Wild and free, baby, we could dream farther than our eyes have ever seen. I don't wanna grow up.
Hi and welcome back. I hope you all managed to get your cup of tea, cup of coffee, the little biscuit and back in your jammies up on your bed or the lounge. I'm just going to talk to you about school vaccination program. I know we talk about this all the time, but I think it's very important that you guys get involved in what we do and understand how we can all work together in ensuring these students are vaccinated. So nothing has really changed in the schedule this year. So our Year 7 students are still getting their DTPA or Boostrix. We don't do Adacel in the school program. They're getting their HPV vaccine as Gardasil 9, and our Year 10 students are getting their meningococcal ACWI Nimenrix. So everything is one dose now. Wonderful. You would think makes things much easier. If you remember from last year, we have changed the way we present our program, and now it's gone all online. Well, we say that with aspiration, that it's all gone online. It hasn't really. It's parents can give consent online, and that was our dream, that everyone would log on through their Service New South Wales account and give consent online, but it hasn't quite worked out that way. But to provide consent, the parents need to log on to that Engage portal there or scan the QR code. And every student in Year 7 and 10 has been issued with one of these flyers to take home to their parents. Lots of information has gone out to parents from the schools to do this. But as we know, we still have paper consent, and we still have a lot of paper consent. So various people will still need a paper consent, and they are, if they can, unable to access the internet, of course. They have no Medicare number. You need a Medicare number to do the online consent. It won't let you proceed without one. If you're unable to provide the Medicare details, or if you're just unable to complete a paper consent form. And we do get a few people that just refuse to do online altogether. So we will always have paper consent. Parents have a lot of questions about school vaccination program. There still seems to be a little bit of a hangover that we're going to come in and do COVID vaccines in the school program without asking anybody. That still grumbles along in the background. So New South Wales Health have a lot of information. So you just need to Google New South Wales Health School Vaccination Program. There's lots of information on there about the school program, how to provide consent. There's a how to provide consent guide, so it's a step-by-step guide if you're getting parents asking you. Vaccine information and product information, and there's actually consent material available in 27 languages on there. Okay, so if you have any people that cannot, English is not their first language, but they do want to provide consent, there's information in there that you can point them to and answer some of their questions. So who's eligible for catch-up in the school program? We're at the point where we say any student with a signed consent form, we will catch them up at any time in school while they're at school. So if they're there on a day, when we're there as a clinic and they have a signed consent form, even if it's from 2 or 3 years ago, we will vaccinate them. So the all online part is actually for the clinician's point of view. So when we go out to a school now, if we do get paper consent, we put them online, onto the online, it's called CARMI platform. So the clinicians use iPads, and we retrieve those student consents on there, and we record vaccination details on there. So it's all done online, and the benefits of having it all done online is that we can access a student air record during a clinic. So we can, a little link down the bottom, and we can see what's in air in case those students tell us that they've had vaccines elsewhere and we're not sure whether we should be giving it today. The other advantage is that the vaccination records that we put on there get automatically uploaded to air that day of the clinic. So there's real-time, accurate records, which is a bonus all around, because there are some kids that don't get done at school. So we go out for a clinic, we will only go to each school potentially 3 times in a year, and as we know with absentee rates, sporting events, holidays, all those sorts of things, illness, some of the kids don't get seen while we're at that clinic, so they will miss. We will offer catch-ups at every visit, so we take every opportunity to catch up students that have missed vaccines at a previous clinic, but there are always going to be some kids that prefer to go to their GP. They're either nervous about vaccination, they're nervous about getting vaccinated in front of their peers. That's a big thing. It's a pretty brutal place in high school. Or they just want to go to their GP. So we support that, and we really encourage you to help us out in vaccinating those students. But can we please ask that you ensure that all adolescent school-based vaccines that you give are put onto air in a timely manner, remembering that the legislation is within 10 days anyway. So most of you, your software even in GPs and pharmacies, we'll put those records onto air automatically. But we need to make sure that you do that. Can I just say, when we're talking in here, if you get a student that comes in and is saying that they haven't had their vaccines, and we look up on their air record, and people sometimes get confused about what's due and what's not due and all that sort of stuff, and tend to treat air as a clinical record. We need to remember that air itself is a program, and it's got set little things in it that will say if this is not done, then that's due, and all this sort of stuff. You need to use your clinical skills and your knowledge of the immunisation handbook and schedules to figure out whether that vaccine is actually due or not. Because given HPV, a Year 7 student might come into your surgery and say that I've missed my school vaccines, it's overdue. You look on air and there's nothing there due, so no vaccines are due. That's because air won't calculate them as overdue until the age of 14 years and 6 months. Okay, so if they're only 13 or just 14, it's not going to say they're due. So please don't be put off with that. Okay, if they're in Year 7 or in Year 10, they're going to be eligible for those vaccines. So we do HPV. It's just worth reminding you that we've gone to a single dose. I'm sure you're all aware of that now. We all clapped our hands when we went to a single dose of HPV, and we all thought that things would make easier, but it hasn't really made things easier. But it's a single dose. The catch-up has now been extended to the age of 25 years. So everybody up to the age of 25 just gets a single dose. Even if they'd had doses before this came in on the 6th of February 23, and they've only had one dose from 3 years ago, that's it, they don't need any more. Immunocompromised people should still receive the 3 doses of the HPV vaccine. We were talking about rates before, childhood rates. We're going to talk about school program rates now. And we like to, I think, blame COVID for what's been going on. But we've seen a little bit of a trend, and this is historic data of HPV vaccination coverage from when we started back in 2008 doing females. We were doing 3 doses, and then in 2016 we dropped a dose, we went to 2 doses, and then in 2023 we went down to 1 dose. You can see here how we've been tracking. So you can see that even before, when we started doing 2 doses, which is well before COVID hit, we started to trend down with the vaccines that were given. We are now sitting at 71% across New South Wales. And when we first started giving the vaccine, we were giving 79%. So we're now giving less vaccine than we were when we first started the program. And one would say that when you first start a program, you're going to have more hesitancy about vaccines. So there's a lot of work to do here. And as the cartoon says, crisis? What crisis? Males is the same story. Okay, we started offering HPV to males in 2013, and in 2023 we are now giving less to males vaccine uptake than we did have in when we started in 2013. So it's a bit of a concern. Meningococcal is a really disastrous story, really. You would think that Year 10 students, a little bit more autonomy, have sense to understand what meningococcal disease is, and would have the forethought to make themselves available to be vaccinated. But that is not the case. So last year it was 63% across New South Wales taking up meningococcal vaccine. And it was 72% when we first started. So I think these guys, just that time of their life attitude, they think that they can outrun anything, any disaster. So lots of work to do here. Reminder that WHO have set a strategy to be eliminating cervical cancer by the 2035, and Australia is set to be the first country in the world to do so. Now, when we first started, this was around 2030. We were thinking that this would happen. To achieve this, amongst other things with screening, etc., we need to achieve a vaccination rate of 90% for girls and boys by the age of 15. Okay, so that's a high bar, and we don't want to be pushing this backwards and backwards and backwards. So we need to work together in providing HPV vaccine to all of these pupils, especially our Aboriginal and Torres Strait Islander women. We know that they are 3 to 4 times more likely to develop cervical disease and have serious outcomes and even death. from HPV, and that's due to a lot of things: inaccessible to a vaccine, screening, hesitancy to be screened, and not having really good access to treatment. So we really need to make sure that we get in there and vaccinate these students. And by waiting to 15, can I just say that waiting to 15 to measure this data is a little bit dire, because the vaccine is best given before these children are exposed to HPV, so there's any sexual contact whatsoever. So that's why we give it at 12 and 13. Vaccine licence from 9, but no one's going to let us go into primary schools and vaccinate with HPV. So we settle for year 7. So we really need to make sure that we can get in at the earliest possible moment and vaccinate these students. So really look forward to working together. But this is a bigger problem than school program, so we can't rely on school program catching all our students anymore. If you've got any questions, please don't hesitate to email me or call me. I'd be most happy to take your questions. I'm going to hand over to Kirsty.
Oh, hi, good evening everyone. So my name's Kirsty Waller. I'm one of the other CNCs in the immunisation team with Hunter New England Health. I'm based in the northern part of the LHD, so I actually sit up in Armidale, so it's lovely to be down here in Wallsend with my colleagues who I don't see that much face to face, a lot of time over the screen. So, and I'm often on the Slido questions. So tonight it's lovely to be here in person and see you all. So I'm talking about cold chain tonight. Now we've talked all about vaccination rates and how important all these vaccines are. Now at the crux of all this is cold chain and keeping our vaccines nice and safe. And we want to protect our vaccines so we can protect our community. So a few key messages. We need to store our vaccines always between 2 to 8 degrees in a purpose-built vaccine fridge. Vaccines are light sensitive, so we definitely need to store them in their original packaging. They need to be stored on the bottom shelf, not to be stored on the bottom shelf of the fridge, and not to be touching the sides of the fridge either. It's very important that we don't overcrowd our fridges, and we recommend the use of open weave baskets as well to store those vaccines. Vaccines can become less effective or destroyed if not stored correctly. Now, the loss of vaccine effectiveness is cumulative and cannot be reversed. Vaccine management is the responsibility of all staff ordering and handling vaccines. So we need to make sure that our staff are doing the cold chain module, which is accessible through the New South Wales Health immunisation site. And that's really important that everyone is aware of how important keeping these vaccines safe are. So why do we keep going on about this? So usually we get it right. Usually we have those lovely pictures on the left-hand side of the slide that show our fridges that are looking nice and ordered, our vaccines stored in their baskets, and with our min-max temperature charts on the front. But sometimes we can get it really wrong. So you can see that the picture on the right-hand side, that fridge is extremely overcrowded. There's no airflow going around those vaccines, and that's really can be really unsafe with the way the vaccines are stored, and will affect their thermostability. So when we're ordering vaccines, we need to order vaccines through the New South Wales State Vaccine Centre. Make sure that we order appropriate amounts of stock, and again, do not exceed the capacity of your fridge. Obviously, we have special immunisation campaigns that are underway at certain times of the year, notably the flu vaccine campaigns. And we have to order additional supplies, obviously at that time. Now, just make sure that you're not overstocking your fridges when you've got your flu vaccines coming in, and if necessary, ensure that you, as I say, not overstocking, but possibly looking at buying a second fridge for your practice facility if needed. There's a really helpful formula in the immunisation, cold chain toolkit about how much vaccine to order. So I would definitely recommend you look at that if you're having trouble trying to work out numbers. Now, it is the responsibility of the authorised practice provider to ensure that the signed declaration when you're doing a vaccine order is true and the practice is compliant with the mandatory vaccine storage and cold chain management requirements. Now, just a reminder that we can only order 2 routine vaccine orders per month. Anything above and beyond that, you'll actually be blocked out of ordering. When you're receiving deliveries, make sure that before you're accepting that vaccine delivery, ensure the cold chain has been maintained and the vaccines were not compromised in any way. So when those vaccines are delivered into your facility, make sure before the delivery is unpacked that you're actually going through that box and finding your cold chain monitor. There's some examples there on that slide to show you what those look like. If the cold chain monitor has been activated in any way, you're to contact the New South Wales Vaccine Centre immediately. Ensure your stock is rotated and checked for expiry. So that's really important when you receive an order, that you're making sure that you're bringing your older stock forward in the fridge, that we're not going to then have the risk of expired vaccines sitting in the back of our fridge. And as Beck mentioned earlier, there's now no need to confirm the receipt of delivery on the State Vaccine Centre site. If you're applying for a new vaccine account, it's now all done online. So for anyone that's interested in applying for a new vaccine account, you need to hop on to the New South Wales Health Ministry site and pop your application in through there. Make sure all those questions are answered again correctly and declaring that everything is true and correct. A notification generally is then sent to us in the PHU, and we will then send you a list of further requirements that we need to see before we approve that application. And also with that, we generally will do a site visit, so whether or not that's in person or possibly a virtual visit. So the monitoring equipment that we require for the cold chain, we all need to have data loggers in our vaccine fridge. So these can be a range of different products: LogTag, TinyTag, cloud-based monitoring. There's all sorts of things out there. Whatever you have in your facility, you need to be familiar with its use and how to download that data. The data logger needs to be set at 5-minute recording intervals, and it needs to run continuously. So all your data loggers need to be, and all your probe needs to be placed centrally in your fridge. We need to download and check data weekly. So it's all very well to say, yes, tick, I've done that data logging download for the week, but not look at any of the temperatures. That has happened on numerous occasions. We've had notifications where a breach has been notified to the PHU possibly weeks after, when another staff member has seen it in the record. So please make sure you're actually checking that data when you download. Save the data on a shared drive so it can be accessed easily by all staff. Make sure that there's more than one staff member in your facility that's aware of where that data is saved and how to send that off to us at the PHU. We need to make sure we service or calibrate and check for accuracy our data logger every 12 months. Min-max thermometers. So you must have a battery-operated min-max for each vaccine fridge and alternate cold storage. So this sometimes will come as a surprise to some clinicians or facilities, but this is a requirement as per Strive for 5 guidelines. And when we're recording our twice daily min-max thermometer temperatures, we need to be taking this off this independent min-max thermometer. So as I said, this is independent to the fridge, and it's an additional requirement to the built-in min-max thermometer that's actually on the top of the fridge. When you're plotting your min-max temperatures twice a day, you need to plot the current, the minimum and the maximum temperatures, and they need to be recorded numerically but also plotted on the graph as well. And twice daily. Now that's twice daily when your facility is open. We obviously don't expect someone to go in over a weekend if your facility is closed and be doing that duty. Very important that we reset that thermometer after recording each reading. That again is often missed. So please ensure that whoever is doing these recordings, that they're very familiar with how to use the thermometers and how to reset. The battery must be changed, obviously when it's low, or at least every 12 months. So hopefully most of you are familiar with this Strive for 5 min-max vaccine temperature chart. So this is a correct way of recording and documenting on this chart. What else do you need to have good cold chain management? We need to have stickers. So these big stickers we need to have on our fridge, near our power points, and at our meter boxes. We don't want a cleaner to come in after hours when all the clinical staff have gone home and be turning off that vaccine fridge overnight to plug in the vacuum cleaner. Really important that that power is going continuously. Obviously there are times when this is out of our control if there's a power outage, but we just need to make sure we have all those requirements in place to prevent any just mishap that's human error. We need to make sure we have regular maintenance of our fridge, our logger and our min-max thermometer as discussed, and like I said, we need to check for accuracy of all that equipment every 12 months. Now this includes doing the ice slurry test. Now again, this information is in the cold chain toolkit and the Strive for 5 guidelines. The other thing too is that we need to make sure that we do an annual vaccine storage self-audit. So that will go through everything that you are required to do each 12 months. And in addition, for any Hunter New England LHD facilities, you will have to do an annual QARS audit as well. This is just reiterating the information I've pretty much just told you, but I thought it's a handy little table that you can find in the cold chain toolkit, and perhaps it's worthwhile printing this out and popping it up on a wall to just show you what the requirements are for you to be doing to maintain your cold chain and keeping those vaccines safe. Now, reporting a cold chain breach. Okay, so this flow chart again is in all those documents. You need to have this stuck on your fridge somewhere so that if there's a problem with your fridge, if it's gone out of that magic 2 to 8 degrees, you need to be contacting us at the PHU. You need to report all cold chain breaches or excursions. Now there is a little disclaimer in that, that it doesn't include temperature deviations in which the temperature reaches a maximum of up to 12 degrees for 15 minutes or less. So obviously we need to allow for a bit of leeway when we receive vaccines, when we're restocking our fridges and we're rotating stock, that obviously that fridge door will be open for a little bit longer, and so we allow for that slight temperature increase. Do not use and do not discard any vaccines until the PHU have provided advice around that breach. Each vaccine has its own individual thermostability data, so you can't assume that all of them will need to be discarded, for instance, or that all are safe. So please do not do anything with those vaccines. Make sure you contact us, pop a sign on your fridge and isolate them until advice has been received. In the event of a power outage, we require the data logging for the entire breach. So if you have an outage that is continuing while you call us, that's fine to notify us and to possibly confirm the sequence of events and what you're required to do. However, we can't actually assess that breach until the power is renewed into that fridge. Obviously at times we have fridge malfunction, so that's a slightly different story. Please contact us again and we will help guide you along the way. So reporting a cold chain breach, for Hunter New England Health, you just need to go to our immunisation website and download and complete our reporting form online, and it needs to be emailed to us at the PHU. When it's downloaded and filled in online, it's much easier for us to more speedy to provide advice, because it's a much more streamlined process for us rather than trying to look at a form that has been filled in and faxed. So section 1 and 2 need to be complete fully and carefully. So please make sure you're reading all those sections well. Section 3 is only required if there's been a fridge malfunction or if the reason for the breach is actually unknown. Section 4, that's where we're reporting the numbers of vaccines we have in our fridge. Please note the explanation at the top of that page around vaccines that have been exposed to a second breach. And don't forget to provide all the attachments as per page 4 on the reporting form. If we receive all this information in a streamlined manner, it does expedite the reply that we can provide and the advice we can give you generally. Just a note on that, we are, as you can see in here, we are a little bit down on our staffing capacity at the moment. So if you do have a breach, the general sort of information or rule that we provide to providers is that you need to allow for 24 hours for our advice to come back. And that is providing we have all this documentation on hand. So if you have a breach that's identified, say, on a Monday morning and you have immunisation appointments booked for lunchtime or possibly later that day, please reach out to the PHU and just ask what our staffing is potentially like that day, or to see if you may need to reschedule those appointments. We do try our best, but sometimes it's just really hard to get things done in a timely manner. Why might the PHU put a hold on your vaccine account? So if we've not received a cold chain breach reporting form or DAR logging or any of the other attachments that are required to finalise the breach, in the event of a suspected cold chain breach, in the event of non-compliance with mandatory vaccine management and cold chain requirements, or if in the event that a deadline is potentially not met, for instance, a random cold chain audit. So at times we will go through and we will send random cold chain audits to providers. We usually give you a window of a fortnight to get information back to us at the PHU. If we've not heard anything in that fortnight, we may go in and pop a hold on your account, which will prevent you from ordering vaccines. So the key messages around cold chain and managing our vaccines well are that vaccines are special and need special care. We need to treat them carefully. Cold chain management is everyone's responsibility, so please don't wait for that staff member that's your expert cold chain management nurse to come back to shift 4 days later to report a breach. If it's identified, you need to be reporting that at the time that the breach is identified. You need to report all cold chain breaches or excursions. Like I said, though, there's that disclaimer in there about that gap of 15 minutes up to 12 degrees. We need to ensure that vaccines are checked and put in the fridge when they arrive. Ensure that you have an independent battery-operated min-max thermometer and that you know how to use it and how to reset it. Ensure that your data logger is set for 5-minute recording and that multiple staff know how to download the logger and attach it to an email. Ensure no vaccines are stored on the floor of the fridge and are always left in their original packaging. And you need to complete your annual Strive for 5 self-audit. Here's a few of the resources that I've talked about tonight. So the Strive for 5 guidelines, the Cold Chain Toolkit and our website. If you actually just Google Hunter New England Health Immunisation, you should come to our website. And that's where you'll find the Cold Chain Breach reporting form. Okay, thank you everyone. Lovely to talk to you. I will now hand over to Sandra, who's from Health Pathways.
Thank you so much, and thank you all ladies tonight for fabulous presentations, for all your time spent preparing them, and also to Pete, of course, and for providing all this fabulous information for our listeners. I'm Sandra Fitzgerald. I'm one of the clinical editors with Hunter New England Health Pathways. Are we currently seeing the login details on the screen? Fantastic. So go to the next slide. Do I have to do that? Oh, there we are. Is that correct? Yeah, sorry. we have listeners from the Central Coast and Hunter New England tonight. So on the left-hand side of the screen, you'll see the login details, and if you would like to, you can use the QR code there. And on the right-hand side, you'll see the Central Coast ones. And I'm just going to show you through a few of the highlights from both of these. How do I get on to looking around the site? There we are. No? Yep, there we go. Right, so this is the Hunter New England site. Yep, no? Oh, sorry. One moment, please, everybody. Thank you so much. So for Hunter New England listeners, I was looking at some of the questions coming through on the Slido, and a lot of them you will find the answers to these on the immunisation pathway. So this is pretty much a one-stop shop for all the information you're looking for tonight. Up in the clinical editor's note, you'll find some of the latest links around JEV, around Shingrix, the latest influenza. Why is this not scrolling? Okay, got it. And RSV. This pathway is set out like all our pathways are around assessment and management and referral. Just some of the highlights. If you go down to assessment 6, you'll find some of the common routine vaccinations, and here is where you'll find the answers to some of the questions that are coming through. For example, there was one around Shingrix and Zostavax, and how soon after Zostavax can you give Shingrix? Hop along into this drop-down box and you'll find the information that you're looking for. Right. Yeah. Apologies, everyone, just some technical issues. Talk among yourselves. We good? Okay, so for just, I think you've missed a little bit of what I've just shown. No, Todd's coming back.
I don't know what. Really giving us a hard time. Let me see if that's...
Okay, if that's not working, I can just talk to the login slide. It's all good? Lost it. Okay. I'm just going to talk in the interest of time. Todd will get us back to the login slide so that you can log in and have a look at what I'm talking to you about. If you go to the immunisation pathway on the Hunter New England site, you'll find all those answers to questions. If you go to the referral section, there's a really great information on how to report adverse events following immunisation, which is what I think Rani is about to talk about. You'll also find how to refer and how to contact these lovely ladies who have been presenting today. Are we good, Todd? No. Okay. And the other section I would really like you to go and have a look at is the Child and Youth tab, because we have just today released a new table of contents there, and there is an immunisation referrals section specifically for child and youth referrals that has got the clinic at the John Hunter for high-risk immunisations and for kids' immunisations and the sorts of kids that you might think about referring in there. I also want to highlight that on the COVID vaccination information page, you'll find all the latest ATAGI advice around boosters for 2024. And some other pages of note are the travel vaccination page and the vaccination in pregnancy page. For those of you on the Central Coast site, it's organised slightly differently. On your immunisation landing page, you'll find immunisation pathways separated into different age groups, so child, youth and adult, and then the pregnancy ones as well, and there's also an immunisation referral page for you to have a look at. I would really love all of you to provide some feedback if you need to. So have a look at those pages. If you can't find what you're looking for, provide feedback. If you go and have a look and you just like it and you think it's great, send us some feedback around that too. But our pages are only as good as the feedback we receive. So if there's something missing or something not quite right, or you'd like something extra, please let us know. And I am going to stop there. Thank you, Todd, for all your valiant efforts to try and get the site up. And apologies for the technical difficulties, but let me know if you have any difficulty having a look around the site. We're very happy to come and do site visits and talk you through it all. Thanks so much. Handing over now.
Oh, it's going to make us go back to the start.
Thank you, Sandra. Sorry that you had some technical difficulties. All good. So I'd really like to introduce Dr. Rani Bhatia. So she's a senior staff specialist in paediatric allergy and immunology at John Hunter Hospital. She's also a clinical lead in the Hunter New England Kids Immunisation Service at John Hunter Children's Hospital. She's a conjoint associate professor in paediatrics and child health at Newcastle Uni and a member of the Academy of Clinical Educators in Newcastle Uni. And our team's had the pleasure of working with Rani many times with lots of different special cases. Rani is a very invested paediatric immunologist whose heart is to get children immunised. So we're really looking forward to hearing from Rani, talking about adverse events and how to go from there.
Okay, good evening, everybody. Sorry I couldn't be there, and I hope this projects and this records well. My name is Dr. Rani Bhatia. I'm one of the pediatric immunologists, allergists at the John Hunter Children's Hospital. I have a long history of association with population health and work together with population health in the Hunter, New England area to address adverse events post-immunization and help assist these families revaccinate their children. So with the next 30 minutes or so, I hope to talk you through some of the common adverse events that you might see when you're vaccinating these children, and I'll also talk you through a couple of case presentations on how we would deal with that when we get such a referral. Okay. So, what exactly is an adverse event following immunization, also what we call an AFI, so AEFI? Well, any untoward medical occurrence that follows immunization is an AFI. Now, this adverse event may be an unfavorable or an unintended sign. It could also be an abnormal lab finding, it could be an abnormal symptom or abnormal disease. And this doesn't necessarily mean that you've had an allergic reaction to the vaccine. So allergic reactions to immunization form a subset of an adverse event following immunization. So what then is an allergic reaction to vaccine? Well, here the immune system has reacted adversely to administration of a vaccine, and that is an allergic reaction. So your immune system here is involved, and that's causing that allergic reaction. So as I said, a subset of an adverse event. And types of allergic reactions can be of two main types. One is your immediate one, which is what causes the most concern to families as well as care providers, which is anaphylaxis. And definitely if you've had anaphylaxis, you need a assessment prior to your next immunization because it can occur again. It can be delayed where it is non-IgE mediated, and in here there is some overlaps between whether you actually had an allergic reaction to a constitutional vaccine or whether it was just an adverse event post-immunization. And it can occur hours to days after vaccine administration. And some examples of that could be a fever, could be a localized swelling, you could have worsening of eczema, you might get urticaria rash, you might get joint pains. Now, this is not an exhaustive list, but these are some examples of symptoms that can happen. So this type of reactions neither increases your risk of anaphylaxis nor is a contraindication for subsequent dose of vaccine, but because of the concern that it may raise to care providers as well as to families, these are the ones that could be referred on again for further assessment. So what is exactly the estimate of a true allergic reaction? Well, it's quite rare. It's 1 in 50,000 doses for TPT and 1 in 500,000 to 1 in a million doses for most other vaccines. So if you look at from a number perspective, it's not all that common. But if you then look at the denominator, which is, the large number of doses that we do administer, it does make it a relatively common problem. So your allergic reaction could occur to a number of vaccine components. Now, that could be the infectious agent itself. It could be the preservative, it could be the stabilizer, it could be the residual media present in the vaccine. It could be the egg protein, it could be gelatin, it could be yeast, and it could be a variety of other additives that are present in the vaccine. So, of course, your most serious AFI is anaphylaxis. But often you can also get a vasovagal episode soon before or after vaccination, and that can also lead to serious consequences. Now, vasovagal episodes is more classically defined in adults and adolescents post-immunization, but generally children and infants rarely faint. So, sudden loss of consciousness post-immunization in young children should be presumed as anaphylaxis to be treated. I guess retrospectively later on, when you kind of break things down a little bit, you might be able to make an assessment that, well, you really didn't have anaphylaxis and maybe had a vasovagal response. But in that moment, I think it would be reasonable to assume if there's a sudden loss of consciousness that it's anaphylaxis and administered adrenaline. So how could you retrospectively look back and say, well, was it anaphylaxis or vasovagal episode? Because it's the most common adverse event you're going to see in your clinics. Well, vasovagal response is often immediate, within minutes or during the time when you're administering the vaccine. Anaphylaxis can also occur immediately, usually within 15 minutes, but can occur a few hours after vaccine administration. Now, in a vasovagal episode, the breathing is going to be shallow and not labored, whereas in anaphylaxis, you're going to see sign of respiratory distress and upper airway swelling. So you're going to hear a stride or a wheeze, you're going to hear a cough. When you then put the heart rate monitor on, bradycardia is what you're going to see in a vasovagal episode, whereas tachycardia will see in anaphylaxis. So just remember, after you give adrenaline and then you put the heart monitor on, you're always going to see tachycardia because adrenaline will induce tachycardia. But prior to giving adrenaline, if you're seeing bradycardia, it's probably a vasovagal response. It's hard to take a blood pressure in little babies, but if you did manage to put the monitor on, hypertension is going to be quite transient in a vasovagal episode and usually will come better as soon as you sit up. Whereas in anaphylaxis, the hypertension is a very late sign and it's sustained. It is not going to get better until you administer some form of treatment, right? And then loss of consciousness in vasovagal episodes usually improves over a period of time. You stimulate and they kind of bounce back. Whereas in anaphylaxis, usually a late sign and suggests a dire prognosis. Also, when you look at the skin with a vasovagal episode, you're going to see generalized pallor, whereas with anaphylaxis, you're going to see redness, you're going to see erythema. Nausea, vomiting, and diarrhea will be seen in both conditions. Patients with anaphylaxis, especially older patients, will identify the sense of anxiety and impending doom with anaphylaxis, not necessarily seen with vasovagal episode. So as I said, treatment is always going to be adrenaline. It is life-saving and must be used. If unsure whether it's vasovagal anaphylaxis, I would often say use adrenaline. I think it is the narrative that follows after the child has recovered that is more important here. So I think it's really important that you communicate with the family at all times and explain why you give adrenaline. Many times it might be, well, I was just being cautious, I don't know what happened. It could be vasovagal, it could be anaphylaxis. I just felt in the moment I need to give adrenaline, the child's recovered. And so you're leaving it open that this may not have been anaphylaxis and that will need to be determined down the road. So you're not closing the door for future immunization. I don't think it's very helpful to say, well, your next reaction could be much more severe. I don't think it's useful to say, well, you may need testing because they may not need testing, right? I think you're going to have to control the narrative to say, well, this is what happened, this is what I did to help your child recover. I don't know, your child probably needs further assessment, for which we're going to put in an adverse event report and talk to Pop Health and get the child assessed in a specialized clinic. And I think that initial conversation is what the families often remember. I think that's really important, that you put the ground rules that and leaving things open for future immunization. I think it's very, very important that we reassure and support. So what are the various vaccine constituents that we can investigate for IgE-mediated allergic reaction? Well, one of the things is gelatin, and it is present in your MMR vaccine, in varicella and Japanese encephalitis, and in influenza vaccine. And so if a patient came to you saying, well, I'm allergic to gelatin, this history is really not important for having and essential for having an allergic reaction, but if they did report that, and there's a documented allergic reaction, then you might need to send them for further assessment before they have their vaccine. I think egg protein is reported as a constituent in influenza and MMR vaccine, but the amount is really, really extremely small. The only significant amount of egg protein is present in yellow fever vaccine, and hence MMR, influenza, etc. are not contraindicated in children with egg allergy and should be administered in the community. Of course, for a specific family, if they are hesitant because of the child's egg allergy, again, please do consider referring the patient to us. But really, from our perspective, the amount of egg protein present in an MMR, MMRV, or influenza vaccine is extremely, extremely small. And even if you have had a severe allergic reaction to egg protein, it can be safely administered. Now, I have heard this, and it's been brought up to me a few times, and therefore I put this in, is casein. It has been anecdotally reported as a potential cause of anaphylaxis after TPT vaccine, and that is because trace amount of casein has occasionally been demonstrated in TPT preparation. However, a vast majority of children with severe cow's milk allergy will tolerate this vaccine, and hence there is no contraindication for a child with cow's milk allergy to not receive the TPT vaccine. The preservatives such as thiamethyl, aluminium, phenoxyethanol do not cause immediate reactions, but they can cause delayed reactions, and often with kids with severe eczema or those who have contact dermatitis, you might get a little bit of inflammatory response at the site of immunization. And of course, we all know that aluminium, which is an excipient and adjuvant present in a few vaccines, can cause persistent nodules at the injection site. The vaccines do contain some antibiotics, which are stabilizers, so neomycin, polymyxin B, streptomycin. So again, these are not common antibiotics that we see in children, but definitely applicable for adolescent and adult patients. So if they've had an allergic reaction, documented allergic reaction to any of these antibiotics, they might need evaluation. And then, of course, with latex allergic patients, we want to use vaccines without a latex stopper. Yeast, and this is something that comes up with the adolescent patients when they're getting the HPV vaccine, that they've had an allergic reaction, or presumably an allergic reaction to yeast, and so they might come to us, and often we would run skin prick test to yeast, demonstrate that they do not have an allergic reaction to yeast, and then administer the HPV. And I have had one patient with a known allergic reaction to yeast who has then safely gone on to have the HPV vaccine without any issues. Now, local reactions can also occur, and these are again fall within the APHE umbrella, and these are usually mild and last for 1 to 2 days. We've talked about the injection site nodules, and a very common one that we hear about is a skin rash 4 to 12 days after vaccination, and often seen in the context of the live vaccine, so varicella and MMR. And again, these are immunogenic, and really almost families need is reassurance. Febrile convulsions is also rare but do occur after MMR and MMRV vaccine, has been known to occur with Bexsero as well, and previously has been known to occur with co-administration of your trivalent influenza. Such reports haven't been seen with the quadrivalent influenza, but can also occur when you co-administer with Prevnar. We see brachial neuritis, so that's inflammatory inflammation of the umbilical nerve, causing pain at the site of administration of the tetanus vaccine. And of course, intussusception has been seen with oral rotavirus vaccine. Commonly, what we get referred about is a hypertonic hypertensive episode, which often gets confused with anaphylaxis, gets confused as a vasovagal response, and sometimes it can be extremely hard to differentiate. But really, an HHE event is a sudden onset of pallor of cyanosis, muscle hypotonia, and reduced responsiveness after vaccination. And here, the difference between vasovagal responses and HHE is that the HHE event can occur up to 48 hours after immunizations and does resolve spontaneously. But it does scare the families. And then one serious adverse event that we see is Guillain-Barré syndrome after influenza vaccine. It's not all that common, but can occur, and in those patients, definitely influenza vaccine is contraindicated in future years. This is something that we get questioned about often, and there's no causal link with immunization and SIDS, autism, multiple sclerosis, inflammatory bowel disease, diabetes, and asthma. So how do you reduce the likelihood of adverse events in immunization? I think what we can do, what's under our control, is always be prepared. So use your pre-vaccination checklist, correct injection procedures, have some knowledge about adverse events of each vaccine, and also provide them with written information. Often you might come across a situation where a family suspects vaccine allergies and will refuse future immunization. And I, in my experience, come across two groups. So one is a patient who has had a possible reaction to prior vaccine, and here you're kind of looking back and thinking, well, was it immediate? Is there other vaccines that you've reacted to, and will you need additional doses of this vaccine or other vaccine similar constituents? And then you have that other group who has a known allergy and worried about an allergic reaction with some vaccines because of its constituents. I often find that in such a situation, when they come for consultation, they've been given a lot of information by other families, but other care providers, but the reason they are in my clinic is because they want to seek more information. So in a way, they've kind of given me consent to address their concern. But I often still will ask that question after I have heard the story. So my advice often is to maintain the trust and keep your consultation brief. You don't want to bombard them with a lot of information. And really, you are the neutral person, right? We are not the enforcers. The enforcers, the government is controlling their tax benefits and their central impairment payments, etc. Our role is to be neutral, to acknowledge their concern, provide them with our experience and advice and knowledge, and allow them to make that decision. So keeping consultation brief, I think, is really important. Important to listen to and acknowledge a concern. I think in your head you might say, well, that sounds like an allergy to me, but I think for them it's an allergy or an adverse event. So really you want to acknowledge that, yes, it must have been quite scary for you, and yes, this might be what had happened, but let's move on from there, right? Always, I find giving them a modified and alternative approach, that hey, let's break up your vaccine, let's do some investigation, and for us it's easy, we might run some skin prick tests, etc., which becomes extremely visual for them. And sometimes they're not ready to make the decision, so always giving them an opportunity to return for discussion is really, really important. And in my head, then I'm thinking, well, future doses of vaccine needed, and sometimes we can measure antibody levels to assess level of protection, and often, of course, providing allergy testing, whether it is to the vaccine itself or vaccine constituents, whether it is full strength or diluted, whether I need to consider intradermal testing. And so when it comes to vaccine constituents, well, egg, latex, yeast are commercially available, but sometimes for things like gelatin, neomycin, etc., we might need to prepare the reagent. So often that first consultation might not be possible, and we might bring them back. So to give you some examples of what I'm trying to kind of address today is I'm going to go through 2 case presentations. So one is this child that Kylie and I recently saw in our clinic. It was an 8-week-old infant, and really here the child hadn't received any immunization. The mother had significant concern. She came into the clinic saying, I'm not an anti-vaxxer, but I had SJS syndrome after my second dose of DPT a long time ago overseas, apparently from Russia, and so they really wanted their child to be tested before vaccinating. They just felt that I had some magic test that I could do. A significant fear. Really, we didn't have any details about the mother's presentation, and SJS syndrome, which is a very severe immunogenic response. It's extremely rare. Yes, can happen with DPT. So really, we in the history, it was acknowledged that yes, this can happen. Right? So I examined the child. There was really no testing unless we gave the child a vaccine. We wouldn't know. So we talked through the immunization schedule. I talked through what the Australian immunization schedule was, and listened to her concerns and offered a modified slow approach. She was still quite resistant, and so after talking about the science, we actually moved on. And my job then was to make that social connection. So we talked about her childhood, how she'd grown up, about her home country, etc. And then offered her the opportunity to contact us after she's processed all the information to return. And she did. Right? And I think as she was leaving from the hospital, was quite convinced that she would actually come back because she loved the life that she gave. And so she returned back, and really we undertook a very modified approach where we broke down all the vaccines for her and gave her a step at a time. And really the first vaccine, she stayed in a hospital for 30 minutes. We had contact numbers, we gave lots of support. And really, she has developed this, really nice trust in our service and prefers to come to the hospital for immunization, which we're happy to offer. And she'll just come to us every 4 weeks, and we'll just keep immunizing this child, hoping that by around 12 months of age, the child will be fully vaccinated for age. Another case that I've seen recently was a 12-month-old, and this child post-immunization had a rash. It came on 24 hours post-immunization, disappeared after 7 days. It was not urticarial, it was not macular papilla, it was more like a dermatitis. And this child really had a history of allergic reaction to egg in the past, and the whole narrative that had been established was that this was because of the child's egg allergy. Of course, she was quite concerned about the 18-month immunization, was fairly convinced this child was going to have anaphylaxis to the 18-month immunization. So really, for me, it was acknowledging the rash. I had a look at it. I explained to her. She had pictures to show, which is, again, really powerful. Which explained to her that it was not urticarial, didn't look allergic. It was rather immunogenic. And the child actually, by the time I saw them at around 14, 15 months of age, had really outgrown the egg allergies. So really, reassuring her about the egg allergy side of things. And so, and acknowledging the concern that she had, offered her the 18-month immunization under medical supervision, and she accepted that. Right, and that was an easy consult. Now, sometimes that may not be the way the conversation goes. So another approach often is, well, we bring them back at 18 months of age and directly do skin prick test with the MMRV vaccine. It's very visual for them. They see a negative skin prick test and then agree to move on to the vaccine given under medical supervision. And sometimes they're still resistant. We might look for antibodies to MMR, and if they are present, we would undertake a temporary exemption. And then when the child's a little bit older and is eaten egg several times, and there are no concerns from that point of view, we might then administer the MMRV. So whenever I put in a temporary exemption here, because they really not clearly fulfilling all criteria of exemption. So I probably put a time limit on it. So I'd give them a temporary exemption for 6 months or 12 months, keeping the door open for them to come back for a conversation. So I think reporting adverse events is really important. Many times you feel, well, had maybe a vasovagal response and they're going to be fine. But it is really the fear that the patients have and what they've heard about that conversation that leads to them declining immunization in the future. So I think at the cold phase, when you're giving a vaccine and there is an adverse event, I think it's really important to acknowledge it, to say, well, yes, exactly, this is what has happened, and let's notify and let's send you on to a specialist clinic for further discussion about it. And that way you're controlling the narrative, and also you're kind of cutting short the social story, because often these families would put it on their social media page and then it just goes out of control. So I also take the opportunity to introduce the HNE Kids Immunization Service. We are now an opportunistic immunization service available through the Children's Hospital. We work quite closely with Population Health. I'm really happy for you guys to contact us for any concerns or advice. I think Kylie is going to be present today when you're hearing my talk, and she might be able to give her contact details. But please do not hesitate to contact us or drop me an email. Thank you.
Thank you, Rani. That was a great presentation. So just a reminder, we've been talking about flu tracking for quite some time through different presentations. This is just a slide to show you how you can participate in flu tracking. It's a great thing to be involved in. I get an email once a week, just a really short survey to see what's going on, and you just respond to that. And that's a way we can keep a picture on how we're going in Hunter, New England, as far as flu, fever, cough, respiratory illnesses. So join up now and become a flu tracker. And thank you very much for your participation. I will now hand over to Phoebe.
Thanks, team. So thank you to everyone for logging on. I think we topped at about 569 people coming online, so that's really, really great. Thank you for spending your precious spare time with us. Thank you to our wonderful presenters. They have a very busy 9-to-5 job, as the rest of us do. So creating these presentations and taking the time to present them to you is really above and beyond, and we do very much appreciate it. Just a reminder, with the Q&A, we will be collating that and getting it back to you. On Slido, you do have the option to upvote questions. Feel free to do that. If there's a particular question you see someone else has posted and you'd really like to see that information, but we're going to be answering as many of them as we can regardless. Also on Slido, I have just activated the evaluation. If you want a certificate, you need to complete the evaluation. Once again, thank you for joining us. We understand that, this does cut into your free time and dinner time and spare time and, on a bad day, extra work time, and we really do appreciate it. So thank you, have a good night, and look after each other.